Hello, my name is Alan Andrade. I'm an associate professor in the Department of Geriatrics and Palliative Care. And my topic that I'll be talking to you about today is digital technology for health promotion and disease prevention in the older adults. I have no conflict of interest or disclosures. And the learning objectives today that I'll be going through would be to understand the dynamic history of digital health technology innovation and their implications for older adults' self-management of chronic disease, develop a historically informed sensitivity to the diversity of older patients and relationship to digital health technology interventions, and identify some of the key reasons for the successes and failures of digital technology interventions for older adults. Technology has always evolved, and in this slide, it basically depicts that our basic form of communication is either through to body language, to talking, to gestures, and that evolved into digital technology where we talk into a telephone handset, into a device that communicates through some form of copper wire across the oceans to a loved one, friend, colleague on the other end holding a similar device, and we're able to talk real time over great distances. That has evolved even further into digital media, billboards, television, and now personal computers and handheld computers, which are essentially computers that we can put in our pockets. And as time goes by, these devices become more powerful. They become more ubiquitous. They are become indispensable. So much so that if I left a personal object of mine at home, it wouldn't matter to me. But if I left my phone at home, I would drive back home to get it. So when it comes to older adults and technology, initially it can be quite uh, the been quite difficult for older adults to be able to navigate. It seems that the younger generation, children, seem to naturally gravitate to new technologies and seem more adept to for onboarding. But older adults find these devices to be sometimes initially to be challenging, but once they get used to them and they become comfortable with them, they also become indispensable to them. So let's talk about some theoretical frameworks that can help us see what make these technologies in general successful. So these are two theoretical frameworks I'd like to talk to you about. The first one is the technology acceptance model. This model was proposed in the 80s when it came to general use of technology acceptance. And it really what it boils down to, if the individual or institution for that matter felt that there was a perceived ease of use of the technology and there was a perceived usefulness of the technology, that would influence the attitude towards using it. It would influence adoption and behavioral intention to use. And if people felt it was easy and useful, that would lead to actual use of the and use and continued use of the technology. Fast forward into the 2000s, another branch or modified version of the technology acceptance model is the unified theory of acceptance and use of technology. And this theoretical framework has a few more factors, which include if there is an expectation that the technology will perform well, if the amount of effort needed to use the technology is minimal, if your colleagues, friends, family use the technology and it seems to influence adoption, and if your institution, your job, your environment seems to suggest that use adoption of the technology will provide value that can also facilitate use of the technology. Other variables such as gender, age, experience, and really acceptance of technology in general can also inflect use behavior of technologies. So these theoretical frameworks are just useful to keep in mind when it comes to adoption of digital technologies and can be applied to older adults. So the problem of unhealthy behaviors, we all face this, and some of the common things include sedentary behaviors, overeating, um, uh, substance use disorder, tobacco use, alcohol use, as well as another example is medication adherence. And the traditional model of how we change these behaviors is by counseling using a patient-centered approach where we try to communicate to patients that these unhealthy behaviors are not good, and trying to overcome these unhealthy behaviors can lead to a healthier lifestyle and longevity and a better health span. However, the time it takes to convince and to encourage and to consistently be on top of patients in order to change the behavior can be a lot, and our healthcare system oftentimes is not geared for that. So, leveraging technology may provide one solution to try to to manage these behaviors. So when it comes to helping older adults in patient education and changing behavior and self-management, there are a number of barriers that come up that can impede educational interventions, and that could be inertia, poor motivation, sensory impairment, cognitive impairment, mood disorders, anxiety disorders, and generally difficulty in interpreting health information, which is health literacy, difficulty in appreciating percentages, numbers, facts that are presented to them, which is low health numeracy, difficulty in navigating data that's presented in a visual or graphical or a computer screen just by the way it's laid out to the older adult. And it may be that the individual might have difficulty navigating the digital device, so much so that they can't comprehend information that's being presented to them on the digital device. So this is a study I did with colleagues of mine at the Miami VA, and in this study we looked at about 250 veterans above the age of 60, and in that particular cohort, we found a very high prevalence of low health literacy, 57%, and we also found higher levels of low numeracy and low graphical literacy, which really goes to show that when presenting data, it's important to patients in order to influence their behavior and to help them understand what they're facing. It needs to be presented in a very simple format, in a way for patients to understand. So when it comes to digital interventions, there are a wide variety of patient-facing technologies that are available. Perhaps the most studied and the most used is telehealth, and that comes in many flavors, including remote monitoring, store and forward. Every health system and enterprise that provides telehealth has different flavors of this particular technology, and also various levels of success based on the geography and the resources available to deploy this, and the challenges that comes along with making sure there's adequate internet connectivity, that the devices are available and serviced, that there's sufficient people to onboard and continue to monitor and assist older adults in use, or their caregivers in using these technologies. There is a lot of data to support its use. It does help patients, but the problems occur when it requires um, once patients lose the novelty of this new device, to get their to get their weight and blood pressure and checked on a regular basis, can be onerous, and there's can be a high dropout rate. However, there is data to support that these technologies are helpful. There is minimal risk, and it can be a challenge for patients and caregivers to use this long term. There is a push more recently, the last decade or so, in terms of using e-health through desktop-based interventions. This includes things like the personal health records, such as the My Healthy Vet from the VA or My Chart with Epic. This has really taken off over the last few years, and has really transformed the care that we provide to patients. Mobile health, also an offshoot from desktop based interventions, is since now most people tend to lean towards having uh, handheld devices that are like iPhone, Android types that are smartphones. There's a lot of technology available now to influence people's health, and it can be deployed to in large numbers to patients. The data, if in support of this, there is data to support, for example, in tobacco cessation. There's some debate. There is some data to support in use for meditation, anxiety, and mental health, that's supported. But the studies that I've done in this area, they're very heterogeneous. The populations are very different. Generally, the outcomes are positive, but as far as clinically meaningful is variable. There's a lot more excitement about using virtual reality and gaming to influence exercise. There is various levels of success with the use of virtual reality and exer games. There is a novelty factor. There's a big wow factor. Most people who use it tolerate it very well. There is data to suggest that sometimes patients have some motion sickness when using VR for the first time or first few times. But generally, people are quite satisfied with the experience. The issue of thus far is these headsets can be difficult to wear for long periods of time, and the novelty factor can wear off, and the use of continued ongoing use of the VR is challenging. And I haven't personally seen a lot of data to support ongoing use to have meaningful impact thus far. Augmented reality is coming also into the fore. Um, I haven't seen a whole lot of data in the healthcare sphere that doesn't. There's not robust data to show, impact in health prevention, uh, in health promotion and disease prevention. But it's the next frontier uh, that's coming on. There's a lot of excitement about the use of artificial intelligence and computerized technology interventions, as well as interactive voice response systems. Interactive voice response systems have been around for some time. They are the ones when you call and you get an automated message and you have to dial a different number to go down a pathway. They it can save a lot of cost to the institution using the interactive voice response systems, but they can be quite onerous, and can lead to a lot of frustration on the part of older adults interacting with these interactive voice response systems. And however, they are many patients are comfortable using these interactive voice response systems. They much prefer speaking to a live individual, I've seen that sometimes older adults prefer to use the interactive voice response systems and take their time through the different options. rather than going online to their personal health records or mobile health records, because it's more difficult to log in and to navigate a graphical user interface rather than a touchstone on a phone. Um, Artificial intelligence has really taken off after the pandemic. There is a lot more use of the personalized home devices that are embedded with artificial intelligence, such as Apple Siri or Alexa. And although it's not specifically, may not have specific features for health promotion, many older adults rely on these smart devices to help, to use them as medication reminders, to make sure that their appliances are turned off, to make sure that their stove is turned off. So these technologies can really assist older adults in their home to in order to promote health. Other ways that these digital smart home devices can help is, for example, in falls, when patients have an unexpected fall and they're unable to reach the phone, or unable to reach a caregiver or friend or family. And these smart home devices can be lifesavers, where the individual, if they're cognitively intact, can use the device to call the loved one in order to get help. So these devices can be life-saving. Wearable devices, such as the some of these devices are can be designed and have features where it can detect a fall, and can also be used to contact emergency services or family and friends. Uh, this is another form of patient-facing technology that can help in health promotion, disease prevention. The robots are something that's being looked at. I believe the Japanese are investing in their aging population to robots for caring for the older individuals. I haven't seen robust data to support its use, but I think generally, given shortages in frontline health staff and aging population, it makes sense to look to see if there are some sort of robots that can assist in caring for older individuals. Automated pill dispensers can there is data to the wide variety of them. They can really help in promoting medication adherence. There are some dispensers that are smart, where uh, smart devices where you can get prompting, and if the system senses that the medication has been taken, you can get reminders, phone calls, can alert loved ones that medications have been taken on time or taken at all. So why is there a push for adopting these different digital technologies? The reason is there's a shift in care from hospitals to ambulatory settings. The hospitals are packed, and they are doing their best to offload their emergency rooms and hospitals by trying to shift to the ambulatory setting. So whatever can be done through these technology to save space and manpower is there is a push and there's a need for adoption of these technologies. And it's all in response to a shortage of professionals and specialists. It can also, there's a decreased impact on remoteness and patients' ability to travel, especially as they get older. Patients and families can be more connected, can interact with their providers through these smart devices. There's also time saving, where clinicians can interact with more patients and uh, can can interact with patients who are different geographic locations, and they can save time. It can also break isolation, improve coping skills, and also help patients connect with the health system so they get them more engaged and activated and involved in the care. And more access, more interaction with health professionals who can really empower and engage patients in self-management, can improve quality of life and well-being of patients, improve safety, as well as allow for better independent living for the adults, improve communication between provider and teams. There is a lot of legislation that has come about to help promote these digital technologies. They're enshrined in the Health Insurance Portability and Accountability Act, the Affordable Care Act, the FDA Safety and Innovation Act, the High Tech Act, and the Section 508 Americans with Disabilities Act. All these different legislation that have been passed through Congress all have provided dollars and oversight to ensure that these digital technologies are protect patient privacy, are held to try to uniform standards to ensure that different platforms are able to talk to each other, and and also that if there's any breach of data, that they're addressed in a timely manner, and there's oversight and penalties for not complying with the law. What's been really helpful with these different acts is that with enforcement and with monies that have been assigned to help promote the use of personal health records, the meaningful use of electronic health records has really transformed healthcare to these electronic medical records and personal health records. So when it comes to creating digital applications, it is now much more involved and time consuming, because not only that you have to do the code review and you have to ensure that the information that you're providing, the clinical content, has been reviewed thoroughly and is applicable to the audience or the patients you're trying to serve. You have to make sure that the data that you collect, the terms that are used, are reviewed and standardized, that whatever information is collected, that data security, privacy, and compliance is there, that there's an enterprise level review of whatever application is being developed to make sure that it's in compliance with the organization, that there is a patient safety assessment to make sure that the data that's collected or presented to the patient will not have some negative consequences, and that whatever data is collected, that there is the patient's privacy and application due to security is in compliance with all regulations, and that the system that is developed is also bearing in mind that Americans with Disability in Section 508 compliance, that the user interface and the user-centric design is taken into view, especially when you're dealing with older adults, and that when an application is put together, that it meets branding requirements of your organization, and that when it's deployed, that you have the enterprise system engineering for integration and interoperability with other enterprise software to ensure it doesn't break the enterprise system. And also that there's a risk level determination review to make sure that if something goes wrong, there's a plan in place in order to address any issues that come up. So my journey into the technology realm really began when I pursued my geriatric fellowship at the Miami VA GREC. And this is 2008, where I was introduced to my mentor, Jorge Ruiz, who is an incredible leader when it comes to digital technology. And he introduced me to digital interventions. He got me excited about how technology has impacted healthcare, how it can help the older adult. And he set me on this journey to explore virtual reality and novel digital applications, specifically digital humans called avatars. And I just wanted to share some of my journey with you all. And this work that I did happened about a decade ago. And I spent about 7 years focused on learning about these digital interventions. My role now is primarily as a clinician, but I've kept abreast of this information. And I think even though this concept has been around for some time now, it's continues to evolve and generate excitement. So what are medical avatars? And let's throw some definitions. So uh, medical avatars are digital humans. They human-like avatars lend credibility. People can find them attractive and persuasive. And the nice thing about it is these digital humans can be manipulated in terms of their gender, their age, or their race. Uh, why do these digital characters work and influence people? Well, it all comes from the primitive mind, and Reeves and Nash in their media equation really put it to try to put encapsulate this concept of, you know, as a caveman, if you saw in the bush stripes rustling in the grass, uh, instead of going to see what it could be, they are the primitive mind would recognize that, hey, it could be danger, it could be a tiger or some sort of animal, and you just run for the hills, rather than go to see what it is, because seeing stripes in the grass could signal danger, and that primitive mind, it exists today. And when we see digital devices, a box with a screen that has a moving mouth and something that looks like human, that communicates, we our minds shift gear, and for a moment, or for whatever time a television movie takes, you really feel that you're watching characters and you're part of this world, that's all make believe, that's on a digital device on a flat screen. And this is all stems from the primitive mind. So how can we use these digital humans? Well, we can use it in terms of helping in self-management by trying to use these avatars to provide knowledge, and using them sequentially to provide retention, skills training, attitude training, virtual coaches as trainers, and trainers to do what? To help people exercise more, to adopt a healthier diet, avoid bad habits like smoking or alcohol misuse, um, good sleep habits, medication adherence, and also to help to serve as companions or peers, especially if equipped with artificial intelligence like features that can assist people with loneliness, people who have cognitive deficits, people who are socially isolated. This is a study I did with Dr. Ruiz and colleagues, and here we use different forms of communication of cardiovascular risk to a cohort of veterans. And in this, we depicted cardiovascular risk in terms of graphical interface with an avatar, without an avatar, and essentially, it you know it we found it was a negative study. We didn't find that these different combinations made, in terms of the patient's understanding and of their overall cardiovascular risk, it didn't make much difference. But one thing that we did notice is that patients who interacted with this technology appreciated the avatar and were more satisfied when they got information with a character there rather than just a blank screen. We also did another study where we looked to try to communicate information in different forms of avatars. We tried avatars with voice, avatars with face, and with avatars with animated face in a study with multiple arms. And we didn't find any difference again when it came to how the data was presented or the knowledge retention, but there was clear evidence of satisfaction when patients saw an avatar as opposed to just a blank screen. And why is it? Why is it that when we see a digital human or a character, or a humanoid caricature on a screen, why is it that we tend to be more satisfied? And it's because we may identify with it more. We may be able to appreciate the content, and more humanize it. And there's a lot of data that from the advertising area that shows that if you put um, uh, actors in commercials that resemble the target audience, people tend to gravitate more and appreciate more whatever the product is. So our group at the Miami VA GREC um, came up with this idea um, to see if what if we looked at avatars, created avatars of participants, of patients, and we went to see, can we influence their behavior? Can we help create a digital human that looked like the participant? Would it influence healthy behavior? So um, with my colleague Dr. Ruiz and the Laboratory of E-Learning and Multimedia Research at the Miami VA GREC, we conducted a randomized control trial to see if an avatar that looked like the patient could influence behavior. And it was a three-arm study. It was a small study, but it was a randomized control trial. And we created this was a pilot study just to see feasibility and acceptability of this particular trial. And we had one arm where there was a virtual representation of the patient exercising, viewing themselves exercise. There was another with an avatar of a generic person exercising, and there was a control edition of the same content with no avatar. This is an example. This is a patient who we took a picture of and modeled an avatar. And we had these three arms with patients seeing themselves exercise and an exercise routine. And they were taught using these different animated avatars to view them, and were given instructions on how much exercise to do, what they need to do. And in this study, there were seven participants in three of the arms. We gave the veterans accelerometers. We had a baseline, and uh, they watched the educational modules, were given instructions, and were given accelerometers with follow up. And then when we got the accelerometers back, we compared the data to see whether there was a difference in exercise activity with the accelerometers. Now, what we found was there were no difference between the three groups. But post hoc, in this very small study, we found that patients who viewed themselves exercised more than the other two groups. Now, this was a negative study. It didn't show differences between the three groups, but post hoc there was some evidence, and our plan was to do a larger study to try to see if we could replicate the results in a much larger cohort. We did not get a chance to do that, but I wanted to share this pilot with you because I thought it was interesting. Another offshoot of that same principle of utilizing an avatar that resembles a participant was used in other area of overactive bladder. Um, Overactive bladder is a condition that includes frequency, urgency, nocturia, and behavioral therapy for active bladder is very effective. And behavioral therapy includes having a bladder diary, adjusting a diet and fluid intake, pelvic floor muscle exercises, simple educational interventions that, if the patient adheres to, can dramatically improve overactive bladder symptoms, or as short a time as 6 weeks. So our GREC at our Geriatric Research and Education Clinical Center at the Miami VA has a long history of helping patients with overactive bladder, and had already developed educational modules in the past to target this condition. And what we did is we used that content and subject matter experts, and we created a 20-minute educational program that covered all these behavioral therapy interventions. And we had two arms. We had one arm which had avatars that looked like the patient providing the educational material, and we had a control arm which did not have these particular avatars. And we checked and monitored the standard outcome measures that we normally do with overactive bladder. We includes overactive bladder symptom monitoring, diaries, self-efficacy, adherence, impact on quality of life, uh, is what we looked at. And this is just a sample of some of the educational materials that the patient saw, and they would navigate these educational modules where they would see these characters that looked like themselves. Now, we didn't tell them that it looked like them, but we shared with them that we would take their picture and in some form they would be used in the study. But we did not specifically tell them that they'll be seeing themselves in the educational intervention. Now, what we found in this study, and this was a small study, I think 20 patients in each group, we found over a 12-week period that there were significant improvements in quality of life and in their bladder diaries. But in one or two of the standard questionnaires, there were no difference. Overall, this was a positive study. We did find that patients um, seem to have gleaned more from the identical educational interventions with avatars that resemble themselves rather than no avatar. And we believe a lot of this is from the advertising world, and the data from the advertising world of having characters that resemble the participant can influence them. So what does all mean? It means that having digital humans, avatars in your educational interventions, and if they resemble or can resemble the target audience, can make them more appealing, and make them more effective in communicating the educational information you want to. It's important to recognize that in order for patients to uh, accept uh, you have to make the information appealing, easy to use, and fun. Developing applications for older adults, in order for it to be effective, you have to make the onboarding and access as simple as possible. The more barriers, passwords, number of steps in order for older adults to access the application, the more difficult it's going to be, and the dropout rate is very high, especially if it's complicated or difficult for patients to find the data that they need to navigate. You really have to make it as simple as possible, and the least amount of interface. A minimalistic design goes a long way for older adults to use applications. One thing I've learned in my journey in use of digital interventions is you have to embed an element of fun in them in order to um, after onboarding someone into these digital interventions, the dropout rate is very high after the novelty factor wears off, and frustration factor builds if there are issues with passwords or navigations. So embedding fun and gamification or game-like features into whatever digital intervention you're planning to create or use uh, in it will really help in engagement and use and continued use of the intervention you're planning. So, in conclusion, digital health is not a panacea. Research is still ongoing. There is a lot of data on variety of health interventions. The studies are very heterogeneous across multiple different countries, states, jurisdictions. Sample sizes can be very small, or they can be very large. But it can be it's difficult to replicate sometimes in different populations based on what internet, what telephone, what resources are available. And what I've generally seen is that if it's a specific problem with a tailored intervention based on your infrastructure, that's what works best. And trying to do a one size fits all, it don't work. Um, Bearing in mind older adults' health literacy, their ability to manipulate information on a digital platform, graph literacy, computer literacy, and education is important in order to have success of any technology. Bearing in mind patients' access to devices, their cognition, their motivation, and reinforcement, helping patients on board is a key to success of these digital interventions. The more complex, the more difficult, the more buttons, the more complicated the interface is, it leads to failure or frustration. These technologies can positively affect ER visits, symptoms such as mood, depression. We've seen that a lot through the pandemic when we couldn't interface with each other or go for visits, appointments. These digital communication devices exploded, and many older adults became very comfortable and familiar with using them, and now some of them prefer it because traveling to doctor's appointment can be really challenging. Embedding gamification and game-like features can help patient activation and engagement and can lead to sustained outcomes. And they don't need to necessarily be part of the technology interventions. It can also be thanking patients for their participation, sending them information for acknowledgement of their work in adopting this technology and how it can benefit their health can go a long way in helping adoption of the whatever intervention you're trying to deploy. Regulation and legislation has been a boon, um, in leading to significant development access and reducing cost barriers. So in summary, I these digital health interventions can have a great impact on patients' health promotion and disease prevention. The data overwhelmingly supports the use of these low cost interventions that are time saving and also reduce labor costs. However, it's important to bear in mind that you have to really focus on solving the individuals or the problem at hand and tailor it to the individual in order for that technology to work best. With that, I'm going to conclude this presentation and say thank you very much.